Hello everybody, welcome to the live stream on Friday at 2 p.m, free Friday 15 minutes I'm calling these. This is number 4 now I think, so I hope people are finding this useful. Before we start, just want to point you to some of my other resources. Let me get myself in shot a bit better, there we go. Just want to point you towards some of my other resources. So we've got my website, which is criticalcarepractitioner.co.uk. A lot of my resources on there, my podcasts, all the blog posts I do, my teaching site you can access through there as well. Just to let you know that there's a discount starting today as well. The Master Mechanical Ventilation course I've dropped from £57 to £27 from today until next Friday. So you can have it at less than half price. So that's just for this week. You can also access my podcasts via iTunes, Critical Care Practitioner Podcast. You can follow me on Facebook at the Critical Care Practitioner. And what else have I missed? Oh, and on Twitter at Critical Care Practitioner. I'm a big user of Twitter, so if you want to follow me on there. And then the other thing I want to talk to you about is the critical care skills with the Critical Care Practitioner Facebook page. These teaching sessions eventually will go over to that Facebook page, so if you want to keep up with them, and hopefully I'm doing these every week, then that would be the place to go. And without further ado, this week we are talking about why we intubate our patients. There's lots of different reasons why, and we're going to cover those now. So let's start with A. So A is the airway. One of the main reasons we intubate our patients is to protect that airway. And we are protecting the airway essentially because what we don't want is any foreign bodies or fluids to get into the patient's lungs. Because if that happens, then that patient is potentially going to become very sick. The lungs don't like anything in there other than air, really. They spend a lot of time wafting out all the microbes and particles that we breathe in, and they absolutely don't like any fluids in there. You can pop a bit of sterile normal saline down there when we're doing things like bronchial alveolar lavages, but other than that, nothing else really. So we're trying to protect the airway from getting something in it that might obstruct it, or getting something into the lungs that might damage those precious alveoli and the airways, which can then cause the patients a lot of problem. So aspiration. So what might they aspirate? Well, they might aspirate vomit. They might aspirate a lot of their own bodily fluids, so blood, and any patient who is vomiting or bleeding around their airway, if they can't clear those secretions for themselves for whatever reason, then we need to be sure to protect that airway, to protect those lungs and make sure that they can breathe properly. It might be that they're at risk of an obstruction of the airway because of things like swelling. So patients who develop a severe anaphylaxis, for example, can sometimes get very swollen upper airways, develop a stridor, which is a kind of strangled sound, and it may be that we might need to intubate that patient to protect that airway, to make sure that the swelling doesn't close the airway completely. And God forbid we might be in the situation of having to do a cricothyroidotomy, which is obviously putting an airway down here. So that might be another reason. It could be their tongue is obstructing their airway. Now, before I started working in ITU, I used to think swallowing your tongue was a thing because that's the way the general public think of it. You can't actually swallow your tongue, but what happens is that for various reasons, let's say somebody's GCS has dropped, that the muscle tone relaxes, a bit like when you're in bed snoring at night, which I believe I'm guilty of. The muscle tone relaxes and can either partially or completely obstruct the airway. So that's when techniques like the head tilt chin lift or the jaw thrust will help move that soft tissue away from the naso and oropharynx to prevent that obstruction. But it could be that if we do things like the head tilt chin lift or the jaw thrust, It could be that we need our hands free to do something else, and ultimately we can't stand there for hours doing that, so we may have to intubate the patient to again look after their airway. Of course, there's elective procedures. We do a lot of operations for many different reasons, and we will need to protect the airway of the patient who is unconscious as a consequence of that. Now, many times today in theatres for some of the more routine operations, they will use the laryngeal mask or the supraglottic airway, as it's more commonly known now, which you may see as part of the Plan A, B, C, D in the approach to intubation. But just as many, as many patients are also formally intubated using an endotracheal tube. And the point of that, the endotracheal tube, is again to protect that airway. And the balloon at the end, a lot of people will say that the balloon is there to keep the endotracheal tube in. It's not. Its purpose is to block off the airway from many of the secretions that may go down. It won't do it completely. You get microfolds in those balloons where secretions can trickle down, which is why people end up with ventilator-acquired pneumonias, for example. But it's also there to make sure that when we ventilate the patient, that the gas going down won't just come up round the side of the endotracheal tube. It does actually go into the lungs. So that's another reason why we might need to protect the airway. So that's A. A lot of A we covered there. B is more about the lungs, issues with the lungs themselves. And two of the main reasons why we might need to intubate patients are because of a type 1 or a type 2 failure. Now, type 1 failure is where the patient has become hypoxic for whatever reason. And we'll talk a little bit about some of those reasons now and when we get to C. It could be that they become hypoxic because they have become septic, for example, which I'll go into detail in a little moment. I'm just checking chat to make sure no one's telling me that actually I'm talking to myself. I may well be. So type 1, they're hypoxic, so their saturations are really low, their blood oxygen levels are low, their PO2 is low, and it doesn't matter how much oxygen we give them. We can't give them enough in order for them to be able to supply their end organs with oxygen. And as a consequence, we might need to intubate them, not to protect the airway, but in order to give them a rest, because they might also be very tired, and also to allow the ventilator to perhaps ventilate them a little better, providing them with higher levels of oxygen, and hopefully, whilst we deal with the problem that was causing them to become so unwell, the ventilator can take over the breathing for the patient. Type 2 failure is slightly different. Type 2 failure is when the patient has high carbon dioxide content, so they're not breathing out their waste gas particularly well. Now, this is clearly a chronic problem for a lot of patients. For the COPD patients, it's a chronic issue, and it's not necessarily something that we can cure for them. And for many of those patients these days, we will elect to put them on non-invasive ventilation. Actually, ventilating somebody who has a COPD, a chronic condition, is not necessarily the best thing to do, because getting them off the ventilator then becomes a bit of a problem, and actually you're not necessarily solving the chronic condition which has caused them to develop this type 2 respiratory failure. So a lot of patients with COPD will respond to non-invasive or bi-level ventilation, and we try not to ventilate those who don't need it, or indeed those who have had such a long-term chronic condition that actually them going into a type 2 respiratory failure is an indication of perhaps the end of their illness, and maybe ventilating them isn't an appropriate thing to do. However, sometimes we do get patients who go to a type 2 respiratory failure for other reasons, or it could be that. What does that mean when you say you can't get into the vent? I've heard that before, but what does it entail? Mike, it basically means that they will, because of their underlying lung disease, so your COPD patients commonly have have problems with the compliance of their lungs. So because a lot of the elastic tissue in the lung has broken down, when we breathe in, when a healthy person breathes in, that's an active process, and when you breathe out, that's a passive process. It's the elastic tissue in the lung that recoils and allows you to breathe out. Patients with COPD through smoking, for example, or antitrypsin deficiency disease, if you're unlucky enough to have that, lose a lot of that elastic tissue. So as a consequence, when they breathe in, they can breathe in, but they can't breathe out particularly well. So the waste gas tends to collect, which is why they retain carbon dioxide. So for them, breathing out is more of an issue than breathing in. Now, if you put them on a ventilator, what will happen is that they will tend to, the lung compliance means that you need to give them very high pressures and high volumes to get them to ventilate properly. And then when you try and wean them off the ventilator, you can't necessarily get these pressures down or these volumes down. And the ventilator, as a consequence, isn't able to clear enough of the carbon dioxide to actually make them well enough for you to take them off the ventilator. So the positive pressure ventilator doesn't do them any favours. They'll end up staying on the ventilator. You can't get the carbon dioxide levels down. And if you try and take somebody off the ventilator with the high CO2 levels, you're probably at the same kind of level with a pH that's very low, which means that they're not that their body functions aren't working properly. A low pH means that a lot of your proteins in your body won't work properly, and a lot of functions will therefore not work properly. So the CO2 retention causing a problem with the acid-base balance, which the ventilator can't really do much about, means you can't get them off the ventilator, and then it just becomes an issue whereby you have to make a decision to withdraw. So I hope that answers your question to a degree. Now I've got to remember where I was, and that's fine to ask questions, by the way. What medications can be used to intubate a patient with hyperkalemia? Well, I tell you, the one medication you shouldn't use is succinylcholine. Sux tends to cause the potassium to go up, and that's one medication you shouldn't use. Pretty much most of the others are relatively safe. These days, rocuronium and propofol are two of the drugs I see used quite commonly, ketamine as well. So I think they're the ones that are used quite commonly. With a hyperkalemia, you'd probably try and sort the hyperkalemia out first, if you can. So you're going to treat them for that. If you can't, if you're in a dire situation and you just need to intubate them, you've almost got to do it at risk. But mainly you can give dextrose and insulin pretty quickly if you need to. You can almost just inject it in if you have to do that to get that very high potassium down, because you do run the risk of, if they're being a bit cardiac irritable, because of the hyperkalemia, you do run the risk of, once you actually intubate them or sedate them and paralyse them, that then just becomes even worse. So you'd probably try and solve that first. Anyway, let me get back to the point. But it's great for you to ask questions. Thank you very much. It's nice to be asked questions. Okay, so that's type 1 and type 2, which is the B. And then let's move on to C. So it could be a circulatory problem that's causing our patient an issue, which means we need to intubate them. Now, one of the most common ones, which requires an intubation, which is circulation, is a pulmonary embolism. So if a patient has a pulmonary embolism, they've got a big clot in their circulation within their lungs. And if it's a clot in one of the big veins in the lungs, you're going to be obviously blocking the blood supply to quite a major part of the lung. So whilst you've got gas going into the alveoli, you've got no blood going past those alveoli, so you've got no gas exchange, which compromises the patient's gas exchange overall. Now, you can give that patient as much oxygen as you like, but if there's no blood going past those alveoli, then it really doesn't matter. You're not necessarily going to achieve anything. So what you may need to do is obviously you might need to give them a clot busting drug, but in the meantime what you're going to have to do is intubate them so that you can give them a maximum amount of oxygen, because they are going to be breathing very hard. They're probably going to be in quite a lot of pain as well, because big PEs can be quite painful. So they're going to be breathing very hard, probably very hypoxic. Let's get them sedated and ventilated, and then we can get the ventilator to look after the ventilation bit whilst we're also trying to look after the clot busting part as well. So a PE is one. Sepsis itself causes a lot of problems to the patient's lungs for lots of different reasons, and eventually sepsis can lead to a situation like ARDS, so acute respiratory distress syndrome. And what's happening here is that sepsis, the inflammatory response of the body, is actually getting a bit carried away, and that inflammation and the productions of things like cytokines make the inflammation worse, means that all the vessels open, they become very leaky, and the same thing happens in the lungs. So the interstitial space, the space between the alveoli and the blood vessels, starts to fill with fluid. And so much so that eventually it increases the gap between the alveoli and the circulation. And it can also start to back into the alveoli as well. So the alveoli themselves can be filled with fluid. And typically the ARDS patient gets big, boggy, heavy lungs, which won't transfer oxygen across particularly well, and we might need to ventilate those kinds of patients as well. So that's the type Cs that might be causing an issue. There could be an element of patients in heart failure, for example. Now, if it's an acute heart failure, sometimes CPAP is better for them, and I'm going to talk about CPAP and heart failure in another lecture. It's not one I want to cover now because it's this kind of subject on its own. I did cover PEEP a few weeks ago, which is similar principles. But sometimes heart failure can cause the patient to have a compromised respiratory system, just as the same as if they have a big MI, for example. It can compromise their gas exchange. So that's C. And then D is about disability. I haven't changed my pictures, have I? I knew I'd forget. So D is about disability. So disability relates to a low GCS, and a lot of these things that I've already talked about will result in a low GCS, but it could be a more direct cause of a low GCS. So it could be that the patient's had a bleed into the brain, be it a subarachnoid or a subdural. It could be a traumatic bleed. They could have had a stroke. And it could mean that they've come in with a low GCS, they're not able to protect their own airway again, and we're going to intubate them to protect their airway while we do the investigations, or transfer them to whichever tertiary centre is going to be looking after them, if that's not where they are anyway. But they're at least going to have to go through a scan or an MRI so that we can confirm, are we going to actively treat this patient? Can we actively treat them? Or sadly, have they had such a big bleed that unfortunately they're possibly going to die, and maybe that's the way that we want to go ultimately. But we won't know that until we've diagnosed the condition. It could be something like an overdose, so it could be deliberate or accidental. So people who sadly take overdoses will commonly take things like opiates, or they'll take a lot of the drugs that we use for anxiety and depression these days will suppress their GCS, and we'll need to protect their airway again whilst we do the necessary investigations, or we wait for the drugs to wear off so that hopefully they will wake up. Alcohol, again, is another possible overdose, be it deliberate or accidental. People who ingest a lot of alcohol, certainly young children, their GCS could be suppressed, and sometimes you have to make the decision that whilst we're waiting for the alcohol to wear off, do we need to protect this patient's airway at the same time? And then finally, something like a DKA, a diabetic ketoacidosis. So if it's severe enough, and sometimes they can be very severe, even with treatment, things like lots of fluid and insulin and dextrose and, checking the ketones and all the rest of it, sometimes they're so suppressed from a neurological point of view that protecting their airway becomes very important. So that's lots of the reasons why we might intubate patients. Now, sometimes we intubate to ventilate, sometimes we ventilate because we've intubated, and I think we cover a lot of those with the A, B, C, D. So that's me for today. That's another Friday 15 minutes. Next week, I'm not sure what I'm going to do. If you've got any big things you want to talk about, stick them down in the chat let me know. I'm always happy to take suggestions. If you want something in particular, just let me know. This will be produced as a podcast as well. So if you go for the podcast, and I'll put the podcast file on the page of my blog, which is all about why we intubate. So thank you very much. Speak to you soon.